So we're going to get into discussing the causes of hypotension, because not all hypotension is created equal, is a recurring theme, and we'll hear about endotypes shortly. And how hypotension occurs should drive the treatment of the hypotension. So all the latest guidelines that are coming out are reinforcing the idea that the diagnosis of the underlying cause, preload, afterload contractility, should drive the treatment of the cause of hypotension. And there's lots of reasons to become hypotensive during all forms of anesthesia. And I've highlighted here in this cartoon on the right that many of you would have seen before, the distribution of blood flow through the different organs in the body, and the important role of the splanchnic bed in being our main reservoir of blood supply in an emergency. So I've been privileged in the past to be bled close to death and to bleed other people close to death in the published literature. And if you take a healthy human, you can exsanguinate at least 25, and if you're young and healthy, 40% of the blood volume in a supine position and not see any change in any commonly measured hemodynamic variables. So there's no change in heart rates, blood pressure, etc., etc. Here's an example of that in the laboratory. So this is a large animal laboratory experiment that I was lucky to conduct with some colleagues in the room. On the bottom left-hand corner, this is a porcine model that behaves very much like adult humans. You can see that there's a 588 ml blood loss. The top left-hand side is the typical bedside monitor. Now, this is a very heavily instrumented animal, positive pressure ventilation, general anesthesia, heart rate 71. So heart rate changing in response to silent hemorrhage is a myth. That happens in traumatic, stressful hemorrhage, not in silent hemorrhage. No change in blood pressure, no change in pulmonary artery pressure, no change in CVP, and so on. Because the splanchnic organs have constricted to maintain a central heart, lung, brain circulation. On the right-hand side, as you look at it, you'll see a downward-facing grey arrow on the trend charts, and that's the point at which the bleed begins. And just to the right of that, there's a timestamp, which is 9:34. The right-hand side, as you look at it, is 09:54. So there's a 20-plus minute period of bleeding. And you will see eventually, the second number down on the right-hand side as you look at it, after 20 minutes and a loss of 588 mils of blood, the mean arterial pressure has just dipped below 70 millimeters of mercury. So if you'd set your blood pressure alarm at 70, it would now be going off. If you look below that, stroke volume is maintained, cardiac output is maintained, DPDT is maintained. Stroke volume variation has started to go up because you're now reaching the point of central decompensation where with each excursion of the ventilator, the stroke volume is going up and down. At the top is a new variable introduced by Edwards Life Sciences based on a predictive algorithm, the Hypotension Prediction Index. It's been alarming for a while now, so it's gone red. If you look at the white line at the top, 15 minutes earlier, it had breached a threshold of 50. So a 15-minute period of time related to the bleeding, whereby it said this patient is hemodynamically unstable. Now, within this series of experiments, of which the first two papers are published under the name of Simon Davis with myself as a co-author, we looked at the microcirculation as a marker of hemodynamic stability or instability, because it's that splanchnic bed that is compromised to do it. So on the left-hand side, I hope you can see it okay, is a side-stream dark field microscope image of the lining of the mid-gut in this porcine model. And you'll have to take my word for it if you're not familiar with looking at these movies. That's nice, healthy gut. It's got nice microvasculature within it. On the right-hand side is after 10% hemorrhage. So you can see that the blood flow is starting to become pulsatile and disrupted. You're starting to see gut mucosal hypoperfusion develop. And that's exactly what we saw using different methodologies when we bled human beings. And those articles are all published. So it is clear that HPI is associated with hemodynamic instability, you can see. So Mike, comments on that, and we'll show something more dramatic in a second.
Yeah, I always think this is profound, and when I teach the residents, I say it's a bit like when you start running a long-distance race and you get a stitch, and that's basically your gut saying, I need a little bit more fluid and blood supply. And we're seeing this in perfect form here. So the problem is, of course, is our patients need volume going on for ventilation. They're having fluid shifts and possibly blood loss. And if we just go on the mean arterial pressure, we can't really see what's happening to the gut and also renal blood flow.
But the correct treatment for this, I'm guessing, because it's relatively straightforward, there's 588 mils of blood in the bucket. What do you think the cause of it is?
It's on the screen, isn't it?
Yeah.
So the reason is hemorrhage. So I think it nicely illustrates that the ultimate goal of hemodynamic management is, of course, not to correct the number on the screen, but to optimize perfusion of the vital organs. And it's something that we don't have routinely in clinical practice. A lot of people advocate for doing those sublingual microcirculation measurements. I personally think that we should actually really measure at the region of interest, like you did here. It makes clear that, for example, just giving a vasopressor to correct a mean arterial pressure value of 60 to 70 on the screen is not the right treatment for this microcirculatory bed that we are trying to optimize.
And this one's easy because we've got the scales with the blood on it, and we've said it's 10% hemorrhage here, so the right answer is volume.
Volume.
Yeah, volume. Okay. So here we see on this slide here, the left-hand side is the baseline bedside monitor showing those lovely hemodynamics that all look normal. On the right-hand side, we've shown what happens after we've made an intervention. So we've made an intervention, and we can see that the mean arterial pressure is 89. The cardiac output's 7.8. The stroke volume's gone up to 101. The stroke volume variation's reduced. Everything's looking great. Mike, successful treatment?
Yeah, well, we've corrected things back to baseline, but of course we still don't know what's happening with the microcirculation.
Okay, so let's imagine I told you that I was on no vasoactive agents and I'd corrected the problem by giving 2 litres of fluid. Would you think I was doing a good job?
Well, of course, we want to know that we're giving the right amount of fluid at the right time, because if we give too much fluid, you've got the downstream issues of tissue edema, ILS, and increased pulmonary dysfunction post-operatively. So I think I wouldn't want to blindly give fluids, I'd want to titrate them to effect.
So Ben, let's imagine I'd given 500 mils of fluid, but I was nervous about giving more fluid because I'm fluid restricting because of my ERAS protocol. So I turned up my phenylephrine infusion, which I had running from the beginning of the case, because now you can't give an anaesthetic without phenylephrine. Am I doing well or badly?
Let's have a look at the microcirculation.
Okay. Yeah. So you've played this game before, haven't you? So on the left-hand side, and this is all in the papers, this is all published, the images aren't, but we can get you access to them, is the euvolemia picture. On the right-hand side, the only thing that's moving now is the blood and dead gut that's flowing around the now edematous villi that have a completely static and stationary microcirculation. So the use of a vasopressor, particularly a pure alpha agonist, in the face of this is quite a marked hemorrhage, 1 litre, but in the paper we do it in small increments. We're just about to publish a paper that has 1% hemorrhage steps. The use of a vasopressor, a pure alpha agonist in particular, in the face of a little bit of hypovolemia is very bad for your gut. That's what we've always been fearful of, Mike, hasn't it?
Yeah, and that's why the surgeons are always pushed back at us. But if you've got the right monitoring, you can correct intravascular volume and then use low-dose vasopressor safely.
Or at least be moderately liberal. You've written a lot of the ERAS guidelines, Mike. Where did this restriction nonsense come from?
Yeah, so we
Sorry
never...
to use harsh words there, but it's,
Yeah,
it's not in any of the guidelines and it's
No,
evidence-free.
it's not.
And you wrote some of the US guidelines. So
I
where
did,
they
yes.
come from?
I did both the ERAS guidelines and the HRQ guidelines with the ACS and Hopkins group. ERAS is all about getting rid of dogma, and now we've got this new dogma that the surgeons have introduced, because all we ever talked about was avoiding fluid overload and post-operative intravenous fluid restriction, which gets rid of the salt and water overload. But we never talked about intraoperative fluid restriction. It's always been the right amount of fluid at the right time, and it's goal-directed hemodynamic therapy, so it's intravascular volume followed by MAP. It's something that I'm having to try and fly the flag to almost correct the surgeons on this, because I don't know if you face the same thing as I do. I might have flow monitoring and I'm giving targeted fluids according to the stroke volume. The surgeon's looking over the drape saying, well, I give restrictive fluid therapies because of ERAS. And I said, well, that's actually not what we said. So it is a problem, Monty, that we have to address as team anaesthesia, I think.
So, Bern, I've showed this to surgeons and they go a little bit pale, and then said, here's what it looks like if I give some fluid to optimize stroke volume and then I give the vasopressor. The microcirculation stays perfect. Do you have similar challenges where you work?
I'm happy to say that our surgeons have a great understanding of hemodynamics. So it's probably something that we together with them developed over the last decade or so. But I think it makes clear that there are different important outcomes. So anastomotic breakdown is a very, very severe complication, but so is acute kidney injury. And we need to balance all of those different things. I can add delirium or acute myocardial injury. So a couple of outcomes that are severe and that we need to avoid. And I think together with the surgeons, we need to make clear that we are working together on one goal, and that is to come up with the best possible outcome for the patient. And at least in my institution, I have the surgeons on board.
Because that image on the right is borderline dying gut. So if you stitch that together, that won't do so well. The gut is now translocating, so the contents of the GI tract are now entering the bloodstream with the lymphatics, clearly described over the decades. Serotonin is accumulating in the gut and is now traveling caudally up into the vomiting center and is driving PON-V. So this is PON-V and ileus in the making.
Yeah, absolutely, and secondary sepsis as well. And it's interesting, isn't it, because we give ondansetron every day in anaesthesia, and we forget the reason that we're giving it is actually because it's basically splanchnic hypoperfusion and serotonin release from the gut.
Treating that on the right-hand side there.
Yeah.
So this is not, the literature now, there's disturbing amounts of reinforcing literature that there's been a change in fashion to give a lot less fluid perioperatively and to give a lot more vasoactive agents. So this is again from the MPOG group, some very famous names and the authors at the top there, publishing in the British Journal of Anaesthesia, that what's happened with mean blood pressure over time, what's happened with fluid use over time, what's happened with vasoactive agent use over time, and what's happened with acute kidney injury over time. If you look at the slide that says crystalloids and colloids, the graph just below the heading there, you can see the amount of fluid has gone down year on year over a 5-year period, such that now in these tens of thousands of patients with multiple centers in the USA, they're clearly giving less fluid. The big thing on the right-hand side shows the norepinephrine equivalents, total phenylephrine, and total norepinephrine going up and up over the 5 years. The bottom left-hand side shows the acute kidney injury and this inflection point at about 10 mils per kilo of the acute kidney injury going up.